And a few more people joining. Welcome, welcome. I wonder if, just to be respectful of everyone's diaries, if we'll maybe make a little bit of a start. I know people will be just logging in at the moment. So welcome everyone to this NHS Research Scotland Ageing Lunch and Learn session. I'm very happy that we have Emily Henderson, who is going to share some thoughts on Parkinson's research with us. But as we often do, I'm going to start with just a little bit of an update of things that are happening in Scotland. So let's see if I can make this work again. If I share my screen, how's that? Can someone just say if they can see that? Anyone?
Yes.
Yep. Hooray, thank you. So welcome. We are running a suite of these lunch and learn sessions. Some of you may have joined us for the sessions from Miles and Debbie, which were both excellent, and today's is going to be excellent as well, but not because of me. A date for your diary is the last Tuesday of the month, next month, when Susie Schenken from Edinburgh will be sharing some thoughts on the challenges and the opportunities of doing research in care homes. So what I want to do before we get to the main course of this lunch and learn, which is Dr. Henderson, I want to just share a couple of other things. I want to just make you aware again of the SHARE resource for researchers in Scotland, but not exclusively for researchers in Scotland. So SHARE is a volunteer resource. People give their details. They often give biosamples like blood, and they have that linked to their NHS data, and it's there for research. So if you're looking to recruit people into a study by a certain characteristic, or if you need, blood tests on a certain person, the SHARE resource is there for you. They are always looking to support new researchers, and the details are on the screen here. And the website is registerforshare, all one word, .org. So do please think about using SHARE. Because you can never have too many webinars in your life, I want to just make you aware of another series of webinars that's happening at the moment, particularly appropriate to this week because this is Dementia Awareness Week. The Brain Health Arc in Scotland are running a series of research training webinars. And there's one that's scheduled for the 7th of June, all around PPIE, how to work with experts by lived experience to make your research better. So if you're someone that does research or you're interested in finding out more about PPIE, do please register for that webinar. The website is there in orange in the middle of your screen, brainhealtharc.com. Also, if you're interested in any of the other topics, like moving into industry, how to get a grant, starting out as a new lecturer, all of those webinars have been recorded and are on the Brain Health Arc website. Each time we meet, I want to highlight a study that is open in Scotland and that's looking for new centres. And the study that I want to highlight this month is the FORCE-C study. It's a study that was developed by geriatric medicine trainees. And essentially, it's looking at measures of sarcopenia, particularly grip strength and association with outcomes. It doesn't involve any medications. It doesn't involve any randomisation. So it's quite a simple study to get involved with. They're looking to open as many sites as they can. They've got all the approvals to open in Scotland. So if this was something that you think you could support in your hospital, then do get in touch with me, and I can put you in touch with the people that are running the study. It's also a study that is using the NIHR Associate PI scheme, which means that a trainee can be the PI on the study as long as they're supported by someone more senior. And I think that's a really useful scheme. And it's a scheme we're going to be promoting more and more for NIHR studies. So all of that and other things are all on our NHS Research Scotland Ageing website. It's also where we're going to archive all of these lunch and learn sessions. This is my reminder that just to check that we're recording. Are we recording, Jackie?
Yes, we are, Terry.
Hooray. I remembered. Okay, so everything you need to know is on the website. But let's get to the main deal, which is our speaker for today, and that's Dr. Emily Henderson. She's Associate Professor of Aging and Movement Disorders and a consultant geriatrician in Bristol. Her research portfolio is mostly around Parkinson's and movement disorders. She completed the RESPOND study, which looked at rivastigmine, and has recently completed the last follow-up for the CHIEF PD study, which I think is the largest academic PD study in the UK. Is that right? Yep. And also as one of the co-chief investigators on prime Parkinson's. As well as all of her Parkinson's work, she's an innovator in geriatric medicine teaching. And she's the lead for the West of England CRN, which will soon be the RDN, and is the former BGS research and academic lead. So there's probably no one better placed to tell us a little bit about Parkinson's disease in the year 2024. So we're going to do what we always do. We'll let Emily talk. Keep your questions till the end. You can either put questions in the chat or raise your hand. Just a reminder that we are recording this, so for asking questions, you may feature in the recording, and if you're not comfortable with that, maybe just put your question in the chat. And just before we let Emily start speaking, a reminder that we're going to run these again after the summer break. So if you have any ideas for people you'd like to hear speaking or topics you'd like covered, do please let me know. But with that, I'm going to stop sharing and hand over to our speaker.
Thank you very much and good afternoon. I'm just going to pause for a second while my slides load and check with Terry that you can see the first slide there.
I can see the first slide. It looks good.
Lovely. Thank you very much and good afternoon. It's a real pleasure and a privilege to be invited to give this presentation at lunchtime today in your series of talks about research. As Professor Quinn has said, my name is Emily Henderson. I run the Aging and Movement Research Group at the University of Bristol, and much of the work that we do in that is focused on Parkinson's research. Those are some declarations before I start. And in the next 30 minutes, I've broadly divided the talk into 3 sections. Firstly, I'm just going to set some context as to what Parkinson's is, recognising that some of you may be very familiar with the condition, others may be working in other disease areas and ageing and less familiar with the disease itself. I'll come on to talk about some research, focusing on research that we've led out of Bristol, but also some other big studies that are ongoing at the moment and we're actively recruiting, and those that are to come in the next 12 or so months. And then finally, the latter half of the talk just talks about the future, particularly focusing on Parkinson's and ageing research. So without further ado, we'll move on to context. So Parkinson's is incredibly common. It affects 10 million people globally, and over the next 30 years, that will double. It's important to know that Parkinson's is associated with age, as in it gets more common with older people, but it is not aging per se. Going back a few decades now, people thought it was sort of aging itself just manifests a Parkinson's disease, but actually there's very separate pathology that gives rise to what's called the Parkinsonian conditions, and I'll talk more about those. Parkinson's, and that's referring to idiopathic Parkinson's, the commonest sort, is the second most common neurodegenerative condition after Alzheimer's disease. It is relentlessly progressive and there is no cure. And that remains one of the fundamental goals of research going forward. So when we talk about Parkinson's, what exactly are we talking about? Well, again, the thinking around this really has emerged. We should consider Parkinson's really as a syndrome, that is to say a cluster or a constellation of symptoms. And many of you who work in Parkinson's and similar areas will remember these sort of slides from medical school. These are what's called the movement or the motor features, and the combination of these 4 features makes up Parkinsonism, that is to say tremor or shaking, bradykinesia, which is slowness of movement, or more accurately akinesia, difficulty initiating movement, muscular rigidity, and postural instability. And it's important to note that postural instability is often a bit forgotten about because it's said, at least, that it's absent in early disease, particularly around the time of diagnosis. but it is the emergence and progression of postural instability, that is the tendency to fall, that very much drives disease progression when it's graded according to what's called the Hone and Yahr score, which is one of the ways you can grade the severity of Parkinson's. So this constellation of symptoms is termed Parkinsonism. And it's important then to consider that Parkinsonism, this syndrome, can be caused by a whole lot of different diseases, the most common of which is idiopathic Parkinson's disease, or IPD. And so when most people talk about Parkinson's, it's IPD that we're talking about. This list, I have to say, is not exhaustive, but under this umbrella come lots of other conditions like multiple system atrophy, dementia with Lewy bodies, progressive supranuclear palsy, corticobasal degeneration, and so forth. There are lots that fall under that umbrella. The reason I've put this up there is that most of the research that is done really focuses on idiopathic Parkinson's disease. But for those of us who work in clinical practice, actually the patients that walk through the door have a whole array of Parkinsonian conditions, and that's one of the limitations of research that's been done to date. Historically, we always thought of Parkinson's as this motor or movement syndrome, but we now really recognise that actually the major burden of symptoms comes from what's called the non-motor, the non-movement symptoms of the condition. So these movement symptoms that I've just described really are like thinking about the tip of an iceberg, but underneath those movement symptoms are really quite profound difficulties that affect people's lives day to day. And a useful way of thinking about these is in 4 domains. Again, these lists aren't exhaustive, but it's all I could fit on the slide without making them look too busy. There are neuropsychiatric complications, so cognitive impairment that can progress to dementia, apathy, anxiety, depression, fatigue, and the list goes on. Really troubling symptoms. Parkinson's disease effectively can affect the whole gastrointestinal tract. People have difficulty swallowing, drooling of saliva, SIBO is small intestinal bacterial overgrowth. They can get gastroparesis, which affects the absorption of medication, and constipation is a very common, almost universal symptom. Their autonomic nervous system goes awry. That can manifest as orthostatic hypotension, that is a drop in blood pressure on standing. That can be asymptomatic, it can be associated with lightheadedness, it can contribute to falls risk, sexual dysfunction, abnormal sweating, and difficulties with temperature regulation. And then the 4th and final domain is really around sensory abnormalities and sleep disturbance. People can get very difficult and refractory pain, restless leg syndrome, something called REM sleep behaviour disorder, where people have very lively nights where they act out their dreams. Things like obstructive sleep apnea can occur, excessive daytime somnolence. So actually a lot of the burden of the condition is in this non-motor domain. I said in one of my initial slides that regrettably Parkinson's is incurable and it is relentlessly progressive. But really interestingly, actually we recognise now that the changes associated with Parkinson's predate the onset of those movement and motor symptoms by at least 10 or 20 years. So if you just look at the axis on the bottom, that's time, and if you take 0 as the point at which people receive a diagnosis, actually, if you ask them, they've often experienced some of those non-motor problems before that time, describing constipation going back 10 or 20 years. They've often described the onset of REM sleep behaviour disorder, hypoosmia, that's the loss of sense of smell, excessive daytime somnolence, and depression, particularly in midlife. Why is this important? Well, if we're thinking about disease modifying or curative therapies, actually we need to potentially target people before the onset of those motor symptoms, and therefore looking at these pre-motor syndrome complexes to identify people who might be at risk of converting to this Parkinsonian condition is really important. As the disease progresses, so do those non-motor symptoms, both in number and severity. People have cognitive impairment, commonly affecting the executive function and visual spatial domains, pain, fatigue. Cognitive impairment can progress, orthostatic hypertension I've talked about as well as urinary difficulties. So that's the non-motor progression, but on top of that, that's the point at which people are diagnosed often when they present with slowness or a tremor commonly. There's worsening of those motor symptoms, and I described originally that postural instability, that tendency to fall very much drives disease progression. And falls and freezing of gait are a major complication and burden, not least because people often fall, they start to restrict their activities, so they're fearful of falling, they end up in hospital with broken bones, the most feared one of which is hip fracture. As if that isn't enough to be going on with, on top of all of that are actually then motor complications and further complications of the therapies that we use, which are predominantly dopaminergic. So over time, whilst we have a very gratifying response to those treatments in early disease, the response varies so that people get a very good response, they can move, and then suddenly they switch off and don't have a response to the treatments. And over time, that on and off phenomena can get increasingly unpredictable. And dyskinesias are often these sort of wriggling, writhing movements that people get, at, generally speaking, at high levels of the dopaminergic therapies. And so those tend to emerge at a point at which people are falling, they have freezing, they have profound burden from the non-motor symptoms altogether. It's very easy to think about this in terms of kind of graphs, and this is something I've adapted from a paper that was written a few years ago now in the Lancet. But actually, what does this really mean for people who have the condition? Well, this is an image drawn by one of the patients that's taking part in the PRIME programme of research, and I'm going to come on to talk about that shortly. And she really described all the aspects of her life that were affected. Her writing is difficult to read because that's one of the manifestations of either tremor or smallness of movement. But you can see here, she's had Parkinson's for about 10 years. She's got dyskinesias, she's losing weight, she's got anxiety and depression, she's fallen and broken her wrists on both sides, I should add, that's why it's bilateral. She's had a hip replacement for a complication. She's falling. She's had a deep vein thrombosis, which was incidental to the Parkinson's. Memory problems, some visual changes, difficulty with her breathing, which sometimes can represent one of those dips in dopaminergic response. She's got thinner bones with osteoporosis, rendering her more susceptible to complications of fall, as we've seen with the broken wrists. So it's worth reminding ourselves that whilst it's very easy to look at these things in very black and white terms, actually the lived experience of people with this condition is it's an absolutely immense condition to try and cope with and live with day to day. And so what arises often when we're looking after people with Parkinson's is this huge degree of complexity. And complexity is quite a complex thing to define in the first place. Complexity for people with Parkinson's arises because of a lot of different things. So the first aspect is all of those different symptoms that are related to the disease itself that I've explained, but also then the complications of some of the treatments we use to tackle those symptoms. Parkinson's, as I said in the very first slide, is a disease of older people. So invariably, we see a lot of older people who also have concurrent frailty, multimorbidity, so lots of other medical conditions at the same time. And as a result of that, you have polypharmacy. So in a sense, you have this multiplicative effect of diseases interacting with diseases, diseases interacting with drugs, drugs interacting with drugs, and it can be a real pickle to try and unravel. And therefore, there's a real art to managing complexity, like there is in managing health in older people. Coupled with that, the extent to which people can navigate the complexity of this healthcare condition really depends on what's called their social capital, their ability to be able to navigate and work out what goes where and how and when to access help. And of course, what their lived experience is of the condition, their socioeconomic position and so forth. And that's very dependent on their physical and mental health function, all in all. The difficulty with complexity is all of those different things stack, and almost invariably, those things stacking up outweigh someone's capacity to cope with that. And that leaves people very isolated, very alone, and subject to lots of difficulties around fragmentation, siloing of care. Because this is the exact moment that you would hope, with people having to live with this huge burden of difficulty, that you'd want a healthcare system that can parachute in to help. So what's the problem? Well, the problem is that care in Parkinson's is fundamentally broken. Parkinson's UK in the 2022 audit really highlighted that there were very profound difficulties with care. They defined a fully integrated MDT as a multidisciplinary team consisting of a movement disorder consultant, a Parkinson's nurse, and therapists that could all see patients in the same venue. And when they took this snapshot audit across all services in the UK that contributed at least to the audit, only 18% of clinics had that available. 10%, so 1 in 10 services did not see people with Parkinson's in dedicated Parkinson's or movement disorder clinics. So these are the people that are seen in, say, general neurology clinics, along with people with epilepsy and all sorts of other conditions. And then really critically, 2/3 of people said that at diagnosis, they weren't presented with sufficient information about the diagnosis. And that's so important because we know how the diagnosis is conveyed really does set people on the trajectory for their experience of the rest of the condition. And we are failing the vast majority of people there. That the NICE guidelines recommend that people with Parkinson's have access to specialist Parkinson's nurses. And actually, when we look at the caseload of Parkinson's nurses across the UK, it's recommended that they have a caseload of not more than 300 people. Over 80% of nurses surveyed saying they're looking after many more. Most people say the median is about 500. And again, a study done back in 2011 revealed that lots of Parkinson's nurses are looking after more like 700 patients rather than the 300. So people are overstretched. The other really interesting study was done, which is the Milton Keynes Community Study. And again, this just shone a really stark light on the inadequacies of care. So 18% of people received what was termed suboptimal care. And suboptimal care was basically going more than a year between seeing a specialist for appointments, or going more than a year between receiving the diagnosis and next being followed up. So people are receiving a diagnosis of an incurable neurodegenerative condition in later life. And then again, 1 in 5 are not being seen for a further 12 months to follow up. So that's pretty stark. Who's most affected by that suboptimal care? Well, unsurprisingly, if you're older, if you've got poorer cognition, if your mobility is worse, if you're in a lower socioeconomic group, or indeed if you're presenting with tremor, then you're more likely to receive what was termed in that study suboptimal care. So not only is care broken, but it's really inequitable as well. And don't worry, I know this is all very gloomy, but I'm setting the scene for need, and then we're going to talk about things we're doing to tackle this. So when we think about the needs in Parkinson's, this is a nice way of looking at it. Parkinson's is a hugely heterogeneous condition in and of itself. It affects people in hugely different ways. They say if you've met one person with Parkinson's, you've met one person with Parkinson's. The difficulty is the way in which we design care really is with this one size fits all. That is, you come to clinic, you get diagnosed, and then generally you're seen on a, at best, 6-monthly or 12-monthly basis thereafter. And it doesn't really matter whether you're in crisis between times, you may or may not have access to an MDT or Parkinson's specialist nurse. You're generally just seen at these 6 or 12-monthly time points, bing, bing, bing. And of course, lots of life happens between those time intervals. So it's actually really unusual that we actually catch people in a crisis. And therefore, lots of things happen and we're not really aware of them. Furthermore, most of the research coming around the circle now clockwise, lots of the research is done is on generally younger people in neurology clinics who have idiopathic Parkinson's disease, and therefore that lacks generalizability to the sort of people with frailty and other conditions and other Parkinsonian conditions that actually step through the doors of clinic. So it's worth keeping in mind that, again, Parkinsonism has a much wider scope than simply idiopathic Parkinson's disease. I've talked already about the fact that patients lack knowledge, and the way in which care services are structured really disempowers them. And there are inadequate treatments. We do have dopaminergic therapies that treat particularly the motor symptoms of the disease, initially very gratifyingly, but many of the non-motor problems are both under-recognised and inadequately treated. People are invariably under a number of specialists, and care is very siloed between those specialists, and as a result really fragmented, and patients can describe that they feel like they're just split into a million different pieces, and the left hand very rarely communicates with the right hand, and patients are falling through those gaps. One of the really critical aspects in Parkinson's is that issues are often detected late and managed reactively. One of the examples that I often cite with this is because of the lack of number of physiotherapists. Often people are not seen by physiotherapists before they're needing a walking aid or they've fallen. And that's really too late. Once people have fallen, the ship has really sailed and it's very difficult to regain function at that stage. We want to look at things much more proactively and prospectively. So what should we do? Well, in the next section of the talk, I'm going to highlight some of the big trials that are either ongoing or recruiting at the moment, who have just finished recruiting or are to come in the next 12 to 24 months. So the first one is called the Top Hat trial. It's run by a professor of psychiatry called Suzanne Reeves at UCL in London. And this is looking at whether a 12-week treatment period with the antiemetic ondansetron can relieve hallucinations. And hallucinations are one of the neuropsychiatric manifestations of Parkinson's disease and often become quite troubling. Often where people develop mild cognitive impairment or dementia, they start to lose insight into the fact that hallucinations aren't real. And that can tip people into psychotic illnesses from which it's really difficult to kind of pull people back. That often means that we have to reduce their dopaminergic therapy. So the Top Hat trial not only is looking at whether hallucinations reduce, but whether or not ondansetron will reduce delusions, how well tolerated it is, and whether it's cost effective. So it was a double-blind randomized control trial with follow-up to 24 weeks, but important to say actually that this trial has just stopped recruiting. One of the great triumphs I should quickly add is that Suzanne was recruiting people with Parkinson's disease, but also Lewy body dementia. But because of some concerns, and that is kind of in the broad domain, that has now been stopped. But there will be lots of very valuable data that emerges from this trial. So watch that space going forward. But just a really good example there of us being able to recruit older people with cognitive impairment and quite troubling neuropsychiatric complications of the disease and Lewy body dementia to a multi-centre national study. The next one is one that I run from the University of Bristol. Some of you will have heard me speak before on the RESPOND trial, which was an early phase 2 trial, looking at whether cognitive enhancement with cholinesterase inhibitors could improve walking and potentially reduce falls risk. When people think about Parkinson's, we often think that the primary deficit, which is indeed the case, is a loss of dopamine in the brain. And one of the things that loss of dopamine does is that it causes walking to become irregular. And when your walking becomes irregular, you're at a higher risk of falling over. And as a result, to try and compensate for that gait and walking change, you have to recruit attentional resources. And attention is very importantly relies on an intact cholinergic function in the brain. But again, one of the deficits that you have in Parkinson's is a loss of cholinergic function. And therefore, the hypothesis of this trial is whether we can augment attention and cognitive function using cholinesterase inhibitors, in this case rivastigmine, which is a licensed dementia drug, to potentially augment cognition, improve walking, and potentially prevent people with Parkinson's from falling. And there were 3 phase 2 trials really that established that this may be an efficacious, i.e. in principle it works, treatment. On the basis of that, we were awarded funding from NIHR to do the definitive phase 3 trial called Chief PD. And this is now recruited from 38 centres nationwide, 600 people, making it the largest ever trial of a novel drug in Parkinson's to be delivered in the UK. And effectively, this is just divides those 600 people into an active arm who received the active rivastigmine patches and the placebo arm who received patches with a dummy medication in. And patients took the drug for up to a year. They were just assessed once at baseline in person and once at 12 months. The reason for mentioning that is this trial was very much designed with older people in mind. And one of the learnings really from the phase 2 trial and our other research is that travelling to hospitals is really quite an undertaking for lots of older people who are not only living with Parkinson's, but are often frail and have frail caregivers. Actually, transport and logistics is a really limiting factor. So we tried to really minimise the extent to which people had to come to hospital for assessment. They came for those 2 assessment visits, and then in the meantime, they filled in diaries recording whether they'd had any falls and how they were tolerating the medicines, and they were also telephoned on a monthly basis from a team based at the University of Bristol to corroborate that falls information. We've recruited 600 people. The last visit occurred in May, which was a great triumph. And furthermore, we are still receiving lots of falls diaries back in the post. It seems like some people kind of saved them all up and then packaged them and send them back to us right at the end of the trial. So I don't have any early results for you at this stage, I'm afraid, but if you do want to come and hear whether or not this worked, and I have to say I don't know the answer to this at the moment because we are all blinded still, I'm going to be presenting some of the preliminary findings at the EUGMS meeting in Valencia in September. So I look forward to seeing some of you there potentially. The next trial I just want to highlight is the CAN PDP trial. This is run by Sagnik Bhattacharya from King's College in London, again, a professor of psychiatry, looking to recruit 120 people to test whether cannabidiol can potentially relieve some of the psychotic symptoms associated with Parkinson's. And that's actively recruiting at the moment. So do get in touch with him if that's something you'd be interested in helping and supporting recruitment for. I've just put a link on the slide there because there's a really, really insightful and lovely BBC feature that was done about really the burden of hallucinations and psychosis in Parkinson's and highlighting the opportunity for people to take part in this trial. So if you do have an opportunity to it's only about 5 or 6 minutes to watch that really nice BBC feature, the link is on the slide there. The next trial, just to showcase, is one that isn't up and running at the moment, but will be in the next 12 to 24 months, and that's the ACT-PD trial. And this is essentially a multi-arm, multi-stage MAMS design trial. These have been used very successfully in other disease areas like MS, and some of the COVID trials use this. And there's now a big initiative run by Camille Carroll in Newcastle and Tom Faultini at UCL to roll out the first MAMS trial in Parkinson's. They've selected the treatments, that's all funded, and I think they're just finalising the next steps of that. So that's a kind of watch this space, and that's to come in the next year or so. Finally, I just want to highlight initiative again running at the University of Bristol with my group, and that's called the Primes Parkinson's Programme. It's run in collaboration with Bas Bloem from the Netherlands, and it's looking at ways we can pioneer and improve some of the deficits that I've highlighted in Parkinson's care on the previous slide. I mentioned originally that one of the difficulties is that care really is designed as kind of one size fits all, and people are seen on this really regular basis, whether they are in crisis or whether they are jogging on with life without another care in the world. Emma Tempson did a PhD with the group and is now a postdoc with us, and she did what's called the Prime Epidemiological Study using data from CPRD, and this is a big general practice data link, and she looked at all of the people with Parkinson's in that and looked at the predictors of negative outcomes. In this particular study, the risk of hospitalisation. The rationale being, if we can predict using routinely collected data the sort of circumstances in which people are likely to end up in hospital, then that would afford us an opportunity to intervene before people go into hospital. That's so important in Parkinson's because people with Parkinson's don't necessarily do very well in hospital. The drugs aren't given in time. That will be very familiar to many of you. They decondition, they invariably aren't able to return to their previous level of function, and sometimes that means a necessity for institutionalized care. So trying to catch people before they're in that moment of crisis and intervene to improve things is the goal of that study, and that paper is currently under review at the moment. So really the goal here would be to time our clinics based on need rather than these fixed follow-ups. The other aspect that Emma tackled as part of her PhD is the fact that a lot of Parkinson's research really lacks generalizability, both to older people, and it doesn't capture people with all of those conditions. So she did what's called the Prime cross-sectional study, where she sought to capture a real-life representative population of Parkinson's patients, and those were the people that we saw at the RUH kind of catchment zone. And we deliberately included people with Parkinsonism. So everyone, whether they had PSP or IPD or Parkinson's disease, dementia or dementia with Lewy bodies or MSA were included. The only people we excluded were those with what's called drug-induced Parkinsonism. So we took that whole population and sought to define the symptoms that they experience on a day-to-day basis to essentially phenotype them. She showed, she recruited over 900 patients and caregivers, making this a really good and large study. And she showed that those who are female, who live in a care home, who are frail or have atypical disease, that is the MSA, PSB sort of conditions, are far less likely to be included. But after ringing them for 10, 11, 12 times, could also show that with really intensive engagement, it is possible to enrol people in studies. The other really interesting findings that arose from the prime cross-sectional study was the interactivity and overlap between frailty, multimorbidity and disability in Parkinson's. And again, we hope to publish that in the very near future. Finally, where are we going with this? Well, of course, the raison d'etre would be to design a model of care that tackles all of those inequities and needs that I highlighted. And that's what we're trialling in the Prime Parkinson's randomized controlled trial. First and foremost, we need to think that if we went out, designed a new model of care and just went out to the people with Parkinson's, said who wants to take part, the people that would likely take part would tend to be those with idiopathic Parkinson's disease, with early stage disease around diagnosis, and who are probably younger and more able. And therefore, what we were able to do was use the population from that cross-sectional trial as what's called a sampling frame to proactively stratify people and over-recruit those people that are difficult to reach, those people that are at highest risk of deterioration. We went out of our way in this RCT to go to people's homes to recruit people who couldn't travel or didn't even leave the house on a day-to-day basis, and to recruit people who are living in nursing homes. The other thing we did with this new model of care was use that risk prediction algorithm that Emma had generated from that early work to stratify the interventions that people were delivered based on that risk. Half of the people in that trial are randomised to just receive their usual care, and the other half receive prime care. And that's integrated. It is focused on very proactive physical activity early in the disease course. There's a single point of access to immediate kind of medical care. And that trial is ongoing, and we will have the results of that next year. And that again was another trial that's recruited to target. I've run a number of studies in Parkinson's, looking at various initiatives to tackle various symptoms, but never, ever have I come across the scenario that we now face with the Prime RCT. And that's that patients who are taking part in the active arm do not want it to end. It is going to end, and it's going to end next year. And people are already writing to us, terrified of what's going to happen when this care package that they're receiving as part of this RCT ends. Some of the quotes we've received is that communication with a clinician should be dispensed just like a prescription, like a medicine. They're terrified what happens with Prime ends. They feel very held. And notably, we're not giving them new drugs. We are, of course, kind of tweaking, buffing and polishing their existing drug regimes, but this is a care interventional trial, not a drug interventional trials. And suffice to say, patients really like it. So where do we go from here? Philosophically, care in Parkinson's is broken. It's a relentlessly progressive disease for which we have no cure. And broadly speaking, I think those two arms of endeavours are pulling sometimes in two different directions. One of the challenges we have, again, so strategically and philosophically, is I think when we think about care, we think of it about it in terms of it being a bit sort of soft and fluffy, like people are sort of holding hands, and here we are ushering people around with Zimmer frames. Of course, that's not how we think about cure, is it? When we think about cure, we think about molecules and imaging and saving lives. I didn't have capacity within this talk to present all the background literature, but actually there are a number of trials that have been done that improve care in Parkinson's that suggest it may well have a disease-modifying effect. And that's demonstrated because when you follow people up and you measure what's called the UPDRS score, which is a measure of Parkinson's severity, people who have novel or active care tend to do much better than people in usual care arms. So it is a new way of thinking about it, that care could indeed be disease modifying. Whilst we are pulling and pushing in different directions, the reality is people are just falling through the gaps of inadequate care delivered in day-to-day practice, and they're falling between the gaps of us having no cure and really very little in the way of care initiatives. And this was summed up really nicely in an editorial from The Lancet in January this year. They highlighted that disease-modifying treatment to slow, halt and reverse the progression of Parkinson's disease must be the goal to strive for. But, and this is the critical thing, in the meantime, improvements in basic and specialist care for patients with Parkinson's disease, supporting caregivers, ensuring access to simple medication regimes, expanding provision of primary and multidisciplinary care for comorbidities would make a tremendous difference to the care and quality of life for millions of patients worldwide. And the essence of that is very much what we are trialling in the PRIME RCT, drawing of that on that fundamental research done by Dr. Tennyson as part of her PhD. So here are my final thoughts. Parkinson's is in many senses an exemplar ageing condition, but we must see it as a syndrome of all of those conditions, and we mustn't think of just targeting people in very early disease. There are many gains to be had across the whole disease course and indeed the disease spectrum. A number of Parkinson's studies are highly relevant to older adults and have showcased how older adults can be successfully enrolled in interventional trials, including drug trials. And looking ahead, it's really paramount, I think, that we need to strive to integrate research that targets both care and cure. That concludes my talk, but I'm very happy to take any questions. Thank you. Harry, you're just muted.
You would think, wouldn't you? After several years of doing this, I'd remember to unmute myself. But no, thank you very much. That was fantastic. Really good CPD and a really good overview of what's happening, and lots of positive comments coming through in the chat. I've got some questions. While other people are thinking of questions, I've got some questions. I mean, first of all, congrats on Chief PD. Getting 600 people with Parkinson's through a study is not an easy thing to do. Thinking about your experience of that and looking back, if you could build a time machine and go back to when you started, what advice would you give yourself on how to get to where you are now?
Oh, Terry, there's the advice that I could give in a kind of setting like this, and there's the advice I could talk about in a more informal basis. What advice? So one of the hugely valuable aspects was that for my PhD, I had done the Respond trial, which was like a mini Chief PD. I recruited 130 people and Chief PD recruited 600. So largely I had trialed a lot of the assessments and regimens. I had called all those patients every month. So I really had a sense of kind of what worked and what didn't. I think if I could go back and do it all again, I would really explore in a huge amount of more depth how we could capture falls without using paper diaries and telephone calls. But, and it is a big but, I want to say on the flip side of that, the fact that often very older people with frailty and this neurodegenerative condition were being telephoned each month to support them with concordance with the IMP and to tackle side effects and to remind them to send the diaries back, I think probably supported adherence in the trial, although we have had a significant number of people withdraw. And I think we need to be brave about that, to say, actually, if we're going to enroll older people who are frail, we need to understand that a number of them are going to drop out regardless of what we do, and build that into calculations around sample size and so forth. And I think the other reflection I have is that we need to have clinicians at the helm in terms of at sites, PIs, and also running trials, who understand medical complexity and risk, and can deal with the complexity of unraveling, is this a side effect of a drug, or is it a complication of the disease, or is it a manifestation of aging, physiology and frailty, for example, ending up the downstream manifestation of which is people end up in hospital and or in some cases sadly dying. So I think you need geriatricians at the helm to manage this complexity in clinical trial settings of new drugs.
No disagreement from me on that. And actually that was I wrote down a couple of questions that you've nicely segued into the next question I was going to ask, which is about who should really own this. So you've shown some trials where the chief investigator is a psychiatrist. You've spoke about the silo nature of Parkinson's, and a lot of people are looked after by neurologists. Clearly, I'm biased, but what I'm seeing is frailty, complexity, multimorbidity, the stuff that's bread and butter for a geriatrician. Who do you think should be owning movement disorder research?
I'm just going to take a neutral stance here and say the people that should be owning it are movement disorder specialists, and there are brilliant geriatricians that can do that, and there are brilliant neurologists doing that. And I think the most important thing is that they're movement disorder specialists, and indeed the psychiatrists are really, they've really got a handle on, psychotic features and hallucinations. Hallelujah. Let's try and pull together, not apart. I think we need a bit more courage as geriatricians to run high-risk interventional drug trials in older people and in Parkinson's disease. There's no reason why we can't do that. Yes, it has always traditionally been the domain of neurologists. There are pros and cons to that, but that shouldn't be a reason that we don't enter into this space and do our best, because we do look after these patients, and I think that provides really valuable insight into the difficulties they face day to day, the difficulties we see in clinic, and therefore the needs that research needs to tackle in that respect.
Yeah. So as well as lots of people congratulating you on your talk, we've got some PIs from the East Coast congratulating Chief PD on the support that you gave to local sites. So I mean, I think that is really important. That can often be what makes a trial sink or swim, and it's not easy to keep supporting sites across the UK.
Thank you. Just on that, one of the things that I am, again, another reflection on the back of that comment, is that I was really minded that sites that were very successful were sites where I often knew professionally the PI at that site and had, a working kind of professional relationship already, and therefore it was really, really easy. And many of the, I don't know which PIs are here, or hello Gordon, it was really easy where we did have difficulties around hospitalizations or deaths or bradycardia. We just kind of picked up the phone and had a conversation, and that was really helpful. It also made the world of difference between kind of n equals 300 and n equals 600 in picking up the phone and reminding people that we did know each other, and please could they redouble their efforts to help get recruitment over the line. And I'm really indebted that people went above and beyond outside of your normal kind of workloads and everything else to see this trial to success. And it isn't my success. It's not a success from Bristol University. It's a success down to all the people at sites and the patients that made it so, and therefore it's really important that we reflect that. Thank you.
Yeah, so lots of questions coming in now. So first one is from Roy, and he's reflecting on what you commented about usual care being so broken and fragmented in Parkinson's, and he asks, do you think that's unique to Parkinson's, or is that something that actually all older people with frailty probably see?
I think it's not unique to Parkinson's, but there is an angle to Parkinson's that is unique, and that's, I think, that we've shot ourselves in the foot for a long time by pretending like Parkinson's is very, very special and a bit elitist. So when people go into hospital, we've sort of disempowered clinicians by saying, don't touch the drugs, no one touch the Parkinson's drugs, and it's special, and therefore only people with Parkinson's can do it. And therefore I think we've disempowered everyone from GPs to junior doctors in hospital from being proactive and kind of holding it with both hands and thinking about how they can improve it. That having been said, yes, some of the problems with silo care, fragmentation, reactive care, leaving people behind who have cognitive impairment, who are socioeconomically deprived and so forth, are universal to ageing and frailty as well.
So we've got some questions here all on a similar theme, so I'll try and roll them together. So one's from Rowan Harwood, one's from Will Whitmer, and they're both asking about how do we measure success and you know, trials that are looking at care. And Will particularly said, if you're thinking about falls, would there be a role for wearables? So I guess a outcome question, but with two parts.
Yeah, so let me tackle the outcome question. This is a really interesting question, and one we really grappled with in the prime complex RCT, because of course, as you rightly point out, we've got people who are 45 who are in active work as architects who have just been diagnosed with Parkinson's, and we've got people in their 90s with very advanced disease and probably in their last year of life living in nursing homes. How on earth do you pick a primary outcome in a trial that's as relevant for the 40-year-old as it is for the 95-year-old? You might pick hospitalisation, but the 45-year-old is not going to end up in hospital in the next few years. The 95-year-old may or may not. You could pick UPDRS, which is a measure of Parkinson's, but there's a lot more going on in people's lives than that. So what we've done in the prime RCT trial is we've chosen people's own goals. So at the start of the trial, they set 3 goals, and at regular points at 3 monthly intervals, they're telephoned by blinded assessors and asked the extent to which they have managed to hold or meet their goals. Oftentimes we've looked at the sort of goals that people have set, which is really interesting, kind of it's the what matters to you question. What are you driven to pursue and continue? And lots of those goals are around physical activity, you know, walking the dog, going to the golf course, things like that. So in this trial, we have sort of pioneered, if you like, using people's own goals as the primary outcome measure. And then we're collecting all the sort of secondary outcome measures you think of in terms of UPDRS, non-motor symptoms, depression, blah, 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 all of those normal ones. The second part of this question, because I'm going on too long, is falls are determined by self-report. Yes, because that was the current when we set out to do this, albeit quite a long time ago, gold standard, that it should be self-report corroborated with a phone call. That's the profane recommendation. Oh, yes, we've considered using falls detectable wearables, but those weren't available and validated at the time we started. If I could go again, and I don't know whether I've got the energy to do it again, I absolutely would want some sort of automatic fall detection system to do that. And that is, I think, one of the major goals of falls research going forward, is having falls automatically detected.
You know, and we're getting close to one, but I wonder if I can just sneakily ask one final question that's something that I'm quite interested in, and it's around, you mentioned if disease modifying therapy is really going to come to prime time, we need to know who's going to be affected really before they're symptomatic. So in other neurodegenerative diseases, the big buzz at the moment is biomarkers. Is that something that we're going to see in movement disorder?
Yes, I mean, it's the focus of so many sessions at all the conferences in terms of what are the biomarkers, and do you take a symptom complex, do you take CSF or plasma, and so forth. And there's lots of interest in that area. I think we're going to need to target people potentially prior to the onset of movement symptoms. There's a whole range of ethics about that. But it's important too that if we look at the parallels with Alzheimer's research, where I don't want to get into this now, but there may or may not be disease modifying therapies on the horizon, those are only going to be as effective as the kind of care infrastructures that we have in place to deliver them. So I think when we're thinking about disease modification biomarkers, we've got to think about establishing the sort of care pathways and infrastructures that would enable us to deliver that sort of disease modifying therapy effectively.
Yeah, agree, and also agree that we don't have time to get into our disease modifying therapies for dementia going to come to prime time. That would need at least another hour. So thank you very much. That's been fantastic. Really, really good. we've got an audience here, but I mean, as I said to you before we started, we found that we get most of our engagement from when we upload the video, and I'm sure lots of people are going to be watching and rewatching this session because there was so much good content in it. So thank you again. Thank you all for joining. And just as a reminder, last Tuesday of the month, next month, we've got Susie Schenken, who is going to talk about care home research. But for now, I will let you all get on with your day. Bye for now.
Bye. Thanks.
Bye-bye.